Welcome to the McMaster Midwifery Research Center Speaker Series. This is a series of regularly scheduled rounds open to everybody, and it's where we like to share the latest in midwifery-related research, obstetrical, perinatal research, all sorts of things that we find interesting, so hopefully you do as well. My name's Beth Murray Davis. My pronouns are she, her, and I'm one of the scientists at the MMRC. We are in a regular Zoom room, so please make sure your microphone is off so that we can hear our speaker. And if you have questions at the end, we can certainly have you open your mic and take questions that way. We are recording the presentation today, and we do share all of our recorded speaker series on our website. So be sure to check back at a later date and share it with any friends that weren't able to join us. Before we begin, I would like to offer a land acknowledgement. I find on beautiful fall days like today, I feel, immense gratitude for the which I find myself, and for the Indigenous stewards who have been here since time immemorial, protecting the land long before we came to interrupt that process. And so I'm mindful of my responsibilities to live in harmony with the original peoples of Turtle Island and to live in harmony with the land. And beyond that gratitude, I think it's important to commit to active listening and learning and unlearning the narratives that have been shaping my understanding and questioning what that looks like in my daily life. So I continue to do that and move forward with steps towards truth and reconciliation and decolonization. And it's something that we talk about regularly at the midwifery program and in our research. McMaster itself is located on the traditional territories of the Mississauga and Haudenosaunee nations, and it's the lands that are protected by the Dish with One Spoon Wampum Belt Agreement. This is our first MMRC speaker series of the year. We try to follow kind of the academic calendar year, so we don't do one in September because it gets a bit bonkers here at the university, but we're now settled into our groove for October, and so this is our first event of the academic year. We have all of our speaker series scheduled on the last Wednesday of the month, and it's always from 12:30 to 1:30, and it's always the same Zoom link. So if you come today and you'd like to continue to come, all of the same information that you use to access today will get you in next time. You can see here the schedule of talks that we have planned for the coming year. So I think a nice variety of topics and lots of different speakers coming and sharing their research and their interests. So in November, for example, we have Celine Lemay and Raymond Gagnon, who will be presenting on professional identity in midwifery, which I think is a fascinating topic. Then we'll pause for December, gather back in January, and we have Lauren Columbus, who will be presenting on the evaluation of a EMCM, the time program at London Health Sciences. February, we have Liz Darling and Sue Faber, who will be presenting on Lyme disease. Then in April, we have one of our graduate students who will be sharing their master's thesis, which is going to be really interesting, looking at psychological and cultural safety in clinical midwifery education, the experiences of students from IBPOC groups. So I think that's going to be a really valuable presentation, and it'll be great to have Trish share that with us. We do also have our MMRC symposium every year, and this year we've moved it a little bit earlier in the calendar year, so it's in March. That's why you don't see a March date on that list. So I'll share a little bit more about that later, but it'll be Friday, March 27th, and it'll be a half-day format, again, online, virtual, and free to attend. So our last speaker series of the academic year will be in May, and that is Susanna, a PhD student working here at the MMRC, sharing critical qualitative case study data looking at the impact of COVID in both the GTA and in Peru. So really interesting studies, lots of variety this year. That leads us to our first presentation, which is Understanding the Prevalence, Context, and Outcomes of Midwifery-Led Waterbirth in Ontario. And our speaker today is Ginny Brunton. So Ginny is an associate professor at Ontario Tech University in Oshawa and a scientist at the MMRC. Ginny is a trained nurse and midwife specializing in community and public health and health promotion. Her research interests focus on maternal midwifery-related health policy and service provision, and looking at interest holder engagement in research. She's a research methodologist with over 25 years experience in design and conduct of systematic reviews, and previously worked at the Epicenter in London, UK. So Ginny will be discussing Waterbirth, one of the options that we know is available to Ontario midwifery clients who are low risk. And to, have I think probably the opportunity to really dive deeply into the born data and the ICES data sets that are available in Ontario. And I think this is the first time this data has been presented, maybe. I could be wrong, but this is going to be really exciting to hear about the cohort analysis of midwifery clients from 2015 to 2021. So we are really excited to have this. Jenny, I'll allow you to share your screen now and pull up your slides as we get started. Our plan is Jenny's going to speak for about 45 minutes, and then we should have time for questions at the end. And when we get to the question period, you're welcome to use the chat box, and we'll keep an eye on that. Or you can raise your hand, and we can have time for verbal questions and exchanges with Jenny. So looking forward to that. Yeah, things look good, Ginny. We can see your slides.
Great. And you can hear me okay?
Sound great.
Oh, good. Okay. Wow, I'm really surprised to hear that this may be the first time that born data's midwifery data has been presented. So I'm honored and excited to be doing it. Thank you for the opportunity to present this CIHR funded work that's looking at the prevalence and context and outcomes of midwifery-led waterbirth in Ontario. I want to acknowledge my co-investigators, Nushin Rotundi, who's a statistician, Sean Morris, who's a neonatologist specializing in neonatal infectious disease, and of course, our own Liz Darling from the MMRC. So let me just find where my mouse has gone. Here we go. Okay, so Beth did a lovely introduction about kind of all my range of expertise. I think that's the thing about being around and in a career for a long time. You start to have a longer and longer introduction. So I'm not going to talk a whole lot about my background because, Beth did a great job. Suffice to say, I've been doing evidence synthesis, systematic reviews for a long time. Always had an interest in maternal, infant health and midwifery topics. And the opportunity came along for me to actually do something that wasn't a systematic review and kind of expand my skill set, my research skill set. So with Liz Darling's support, I did that. I've had a career where I've looked at a lot of topics in sexual and reproductive health. So it's an ongoing interest of mine. So in terms of water birth, we know that midwives seek to promote healthy beginnings for women at low risk of complications. And water birth is one care option that's available. Clients really highly value water birth, and research suggests outcomes that are similar to birth on land. So clients cite increased agency, autonomy and control, liberation, and even transformation. And in terms of, evidence of safety and effectiveness, water birth has been associated with decreased pain, decreased medical interventions, and decreased postpartum hemorrhage, as well as increased maternal satisfaction. Now, some evidence suggests that neonatal infection rates are higher in hospital-based births compared to land-based births, but these findings weren't statistically significant, so it's kind of a questionable. And when you kind of look at neonatal infection, it tends to be a hot topic in relation to water births, and it tends to make people a bit twitchy about offering water birth as a service option. So the evidence on neonatal infection and water birth is a little cloudy. The neonatal infection rates have been shown to be unclear around the role of place of birth, but also that the type of organism varies quite widely. And severe infection, waterborne bacterial organisms like, Legionella or Pseudomonas, they might occur more often in out-of-hospital births. But other infections like multi-drug resistant infections might occur more often in hospital. The types could adversely affect infant growth and development. So group B strep has been implicated in neonatal infection attributed to water birth with serious impacts on infants. But as a colonizer of the birth canal, group B strep is more likely to be acquired during vaginal birth. So there's a potential confounder there. And other case reports of neonatal infections kind of questionably attributed to water birth showed, air or body fluid-borne infectious organisms that are more often associated with land-based births. And then other ones even suggest, non-severe infections like conjunctivitis. So it's really kind of unclear what role water birth is playing in neonatal infection. So, because each of these organisms carry a different burden of illness for the infants. And so, as a result of some of this controversy, there's questions around safety of water birth with respect to neonatal infection and also cord avulsion, right? There's literature that suggests there's higher rates of cord avulsion with water birth. The numbers are very, very small, and a review of case reports on how those were handled indicate that they're easily mitigated. They're easily resolved. There's low long-term outcomes from it. But still, it's sort of a controversy. So because of this uncertainty, professional and national health policy on water birth varies considerably, right? So, for example, the American College of Obstetrics and Obstetricians and Gynecologists discourages water birth outright. NICE, the UK body that provides guidelines for health interventions, they recommend that caregivers inform women that there's insufficient high quality evidence to either support or discourage giving birth in water. SOGC recommends its use in acute care facilities with trained staff and appropriate equipment only. AOM, the Association of Ontario Midwives, and other Canadian and provincial health services and professional organizations encourage it, but not all of them have guidelines. And finally, the family-centered maternal and newborn care guidelines that are across Canada guidelines for maternity care, they make no recommendation, but they illustrate this range of opinions. So the advice is kind of all over the place on this. So we thought this is probably a good opportunity to look at methods, particularly in Ontario, because here the characteristics of clients in Ontario who choose water birth is currently unknown, as are the outcomes for mothers and infants. So we were curious to know what it looked like. And happily, we have this wonderful provincial data set of routinely collected maternal and infant care data, the Better Outcomes Registry and Network, BORN data set. So we undertook a study where we aimed to understand the prevalence and characteristics and outcomes of water birth compared to land birth in low-risk childbearing people receiving midwifery care in Ontario. And to do that, we utilized the Better Outcomes Registry and Network, or BORN, primarily. And this was linked with a series of other administrative and health data sets from the province. So that included the Registered Persons Database for individual demographic characteristics, the Canadian Census and Postal Code Conversion File Plus, or PCCF Plus, for area level demographic info, the Discharge Abstract Database, or DAD, for neonatal infectious disease information, and the National Ambulatory Care Reporting System, or NACRS, for hospital emergency visits related to neonatal infection, and the ICS institutional database for hospital locations and characteristics. We also were guided in this work by an advisory group that consisted of hospitalist and community midwives and managers, a nurse, and also a member of a water birth advocacy group, a national advocacy group. Analyses here were conducted through ICS McMaster. And do I have something here to tell you a little bit about ICS McMaster? Yes. They're an organization that uses secure linked health data to study healthcare delivery and outcomes in the province to inform healthcare policy and improve the health system. So ICS conducted all analyses, and analyses were conducted from 2015, January 2015 to March 2021. But in this presentation, we're reporting up to the end of 2020, just because we didn't have a whole year's worth of data for 2021. So you'll notice when you're looking at graphs that, it goes up as high as 2020. But I will talk about that a little bit more. So more about the statistical analysis. We used propensity score adjustment methods, and the outcomes were modeled using logistic regression analysis, and we generated relative risks using generalized estimating equations. And we also undertook some subgroup analyses. So we were interested to know if there was a difference in water birth prevalence before and during the COVID-19 pandemic. We were interested to know if there were differences in any of the outcomes in our model based on infant sex or birth setting, if birth setting made a difference in terms of neonatal infection. So the primary objective was to understand the prevalence of water birth. And in terms of the outcomes, our primary outcome was severe neonatal infectious disease. And our secondary outcomes for newborns was neonatal resuscitation, neonatal mortality, and breastfeeding at 6 weeks. And maternal secondary outcomes were the presence of intact perineum or not, postpartum hemorrhage, and obstetric anal sphincter injury, or OSI. Right? So now we get to the good stuff. The descriptive or unadjusted results. In terms of our cohort, assembling our cohort and what we got, we were looking for all-term singleton cephalic births in Ontario under midwifery care between January 1st, 2015, March 31st, 2021. The born dataset identified over 140,000 of those births. And then we excluded any that were under midwifery care but then transferred to a physician during pregnancy, any that experienced miscarriage at less than 20 weeks or an induced abortion at any gestational age, fetal death, stillbirth, severe congenital anomaly, and then excluded any conditions that were classified as requiring physician care, and then pre-existing maternal health conditions. And then finally, any births that were not a spontaneous vaginal birth. So after we ran through all of those exclusions, we were left with 80,610 births, midwifery-led births to look at. So we got to calculate our prevalence from that. So we had 5,002 water births, which gave us a prevalence rate of 6.21%, which is great to know. And then we started exploring the data a little bit and said, okay, what's the prevalence across the years of the study? And found that it was fairly consistent. It ranged between 5.3% and 6.9%. You can see kind of in 2020 that the numbers dropped down. And this is interesting. Again, the pandemic was happening during that year. And as I mentioned in the methods, 2021 was removed from reporting because it's a partial year. There was only 1,814 births in that 3-month group for 2021, and 94 of those were water births. So the proportions remain similar to other years. We did also look at that. So it is consistent. In terms of baseline characteristics, we looked to see if there were any statistically significant differences between people who experienced water birth and people who experienced land birth. Water birth clients were similar to land birth clients in terms of their material deprivation quintile, the infant sex being small for gestational age or their gestational age at birth. But people who utilized water birth were more likely to be older, so 35 years of age or older. They were more likely to be Black or Caucasian ethnicity or race, French speaking, multiparous, not having a prior cesarean section. They tended to be rural residents or repeat clients. So the characteristics of people who are having water births looks a little bit different from those who have land birth. And those were all statistically significant at p-value being less than 0.05. So we also looked at the prevalence by the health region, so where in the province water birth was taking place. And so we looked at health regions, Ontario health regions, which are administrative areas that are defined by the provincial government to organize and deliver healthcare services. And you can see that water birth is fairly equally distributed kind of in that bottom part of the province across the west and east and central Toronto regions. And then when you look up in the northwest and northeast regions, there's quite a bit less water birth going on. Now, when you look at population density of the province, that might give us kind of an idea about why we're seeing the numbers that we're seeing there, but that's just one aspect of thinking about what might be going on. So, sorry, let me just go back for a second. So these prevalences are for each region, what is the prevalence rate in comparison to all water births in the province? So then we also looked at within each region, what is the proportion of water birth compared to land birth? And the interesting thing about this slide is that in the Northeast region, which you can see here at the top at 6.7%, it accounts for 6.7% of all water births in the province. But when you look at how it compares to how many land births are happening in that region, it's got the highest prevalence rate. So there's actually more water births going on proportionately in that region compared to all the other regions in the province, followed next by the eastern region, which is kind of over, Leeds, Grenville, Lanark, kind of from Pickering east. So, the data suggests that there's variation in how much water birth is occurring in each region. Now, this is one that I think people will be really interested in, looking at place of birth. So where is water birth taking place? And what we found, perhaps unsurprisingly to midwives, is that over almost two-thirds of the water births are taking place at home. And that's followed by almost 20% taking place in birth centers. And hospitals are kind of further behind at only 11.4% of all of the water births. So again, an interesting finding. Other locations, 3.2%, that is accounting for midwifery practices that are set up to do births. So there's a small proportion that are happening in places like that too. So the outcomes for infants, we said we were interested in looking at neonatal infection. And the unadjusted results suggest that, good news, the water birth infants are 40% less likely to experience neonatal infection. Statistically significant finding, okay? And we found non-statistically significant findings for infection severity. Because the confidence interval passes 1.0, that tells us that finding's not statistically significant. So what that means is we didn't find any evidence of a relationship between severe neonatal infection and water birth. So that is good news. In all of the other outcomes that you could look at, less likely to require resuscitation, water birth infants, no difference in breastfeeding education or support, non-statistically significant findings for neonatal death. Again, there's the relative risk looks like higher, like maybe there is a relationship, but again, because the confidence interval is over 1.0, those findings are non-statistically significant, so there's no evidence of a relationship there. But we did decide to go in and actually look at the cases. So what were the causes of death for those infants? And because of the very small numbers of neonatal deaths in that group, we can't share those causes of death publicly because that's an invasion of privacy. But we can say that we looked at those causes of death and looked at the mechanisms behind them and determined that there was no evidence of a direct link between water birth and neonatal death. So that's good to know. That's reassuring to know. And again, less likely to have respiratory distress, less likely to be admitted to NICU, less likely to experience any of the WHO danger signs of infection, which is kind of a series of 2 or more signs of not feeling well: convulsions, drowsy, difficult to wake, movements only when stimulated or have no movements, fast breathing, grunting, chest recessions, temperature instability, or cyanosis. So they're very broad, generalized signs of infection. Those signs tend to be used more in low and middle income countries. And the signs themselves as a tool, I don't think has been well validated. So, it's good news that they're less, in this study, we found they were less likely to experience those signs. But I think there's more work needs to be done on that particular tool. And then finally, no evidence of a relationship between water birth and low APGAR scores at 5 minutes. For maternal outcomes, all good news as well. 19% more likely to have an intact perineum, 65% less likely to have OC, which is great. No evidence, again, for postpartum hemorrhage. Okay. But we did find that they were 23% more likely to have other postpartum complications. So we looked into that a little bit further. And what we found was that the cases, so what we're talking about here is 313 out of 5,002 water births had some kind of other postpartum complication, okay? And roughly the same proportions experienced either some kind of infection, which could be considered, not severe, to late postpartum hemorrhage or postpartum depression, which could be considered severe complications. But they're roughly about 1.5% in each case of 313. And then we had 4 categories where we couldn't really make any judgments because we weren't given more information. So other not specified was listed, multiple conditions that weren't specified, unknown, so there might have been missing data there, or they were other specified, but they were suppressed again because they were very small numbers, and revealing that condition could violate privacy for those participants. So, in those cases, we get a bit of a picture about the balance between severe and non-severe complications, but note that the numbers are extremely small in this cohort. And of course, we looked at a whole bunch of other outcomes. Medical intervention outcomes, length of time with labor, and then of course complications like shoulder dystocia, manual removal of placenta, and postpartum transfer and maternal infection. All good, all in favor of water birth. It's important to explicitly acknowledge that the associations that are reported in this slide aren't confirmation of causation, okay? It's very likely that for several of these factors, the factor itself or the signs of increased risk of a factor might eliminate the possibility of water birth. So for example, if a client wants an opioid or they want an epidural, they have to get out of the birth pool. So, those numbers look really good, but you have to remember that's people who didn't have any complications and were planning to have a water birth probably. So they weren't going to get out and have an opioid or an epidural. So just to keep that in mind. Okay, so that's the unadjusted results, but we have to kind of account for all of the things that could influence the results that we're seeing. So we did some regression and created a model to test, the relationship between water birth and some specific variables. So we chose We drew on a large list of variables within maternal, medical, obstetric history, labor and delivery characteristics, healthcare and health system variables, and I'm happy to talk about those afterwards in the questions. But we chose 5 outcomes for our model. So neonatal infection, because that was the specified one, neonatal resuscitation, breastfeeding at 6 weeks, intact perineum, and postpartum hemorrhage. So these 5 outcomes were finally decided on by our advisory group. Ozzy was dropped as our ICS data analyst advised us to choose only 5. And intact perineum and Ozzy were kind of seen as 2 sides of the same coin. And the unadjusted results showed such a decrease in Ozzy rates. We thought it was probably more important to look at intact perineum, particularly from a salutogenic point of view. This is one of the good things that happens. So we should be looking at these rates to see if they vary. And so this was agreed on by our advisory group members that these were the outcomes we should look at within the model. And so we looked at all those covariates that I mentioned earlier and modeled them to sort of think about how they influenced each other, how they influenced water birth, how they influenced neonatal infection. And we drew these, they look really complicated, but they're not. Directed acyclic graphs. And so based on literature review about factors that influence each of these outcomes and our advisory group consultation that we did, we came up with these directed acyclic graphs for each of the 5 outcomes. So the one that I'm showing you here is neonatal infection. And if you're kind of looking closely at it, you can see there's like little arrows between age and parity, and then between parity and induction, and then between induction and water birth and neonatal infection. So we modeled the directionality of the relationships and to test them. And the links that are along the right-hand side are actually the web links. If you want to go and have a look at the actual covariates and the models that we developed, you can do that. We're happy for you to do that. And this is our adjusted outcomes table looking at water birth versus land birth for those outcomes. And I've ordered these here a little bit differently. The maternal outcomes are first and then the infant outcomes. But you can see that once we applied all of those covariates and accounted for all of those factors that might influence the relationship between water birth and each particular outcome, what we were left with were that Ontario midwifery clients who give birth in water are 4% more likely to experience an intact perineum. So that is a small effect. And their infants are 24% less likely to require neonatal resuscitation compared to Ontario midwifery clients who give birth on land. And results for all of the other outcomes in this model were not statistically significant. So that's good. We know for sure that there's a small improvement in the likelihood that you're going to have an intact perineum and a moderate reduction in the risk of newborn resuscitation. In addition to that, we wanted to have a look at subgroups. So we wanted to know if there were any differences between male and female infants on any of those outcomes. And what we actually found was that male infants born in water were less likely to require resuscitation compared to female infants, which is interesting because usually male infants are the ones who run into trouble, but if that's anecdotal. Pre-COVID versus COVID years. So we had data for 2020 and part of 2021, and there were differences, statistically significant differences in the rates of neonatal resuscitation prior to COVID compared to during COVID. And then finally, birth setting, we looked at the risk of neonatal infection based on birth setting, and there was no statistically significant evidence of any differences in neonatal infection by birth setting. So that's interesting because it's slightly different than what has been talked about in the literature. So our main findings demonstrated that water birth prevalence is consistent with other jurisdictions. So when you look at similar studies that have been done in Alberta and British Columbia and in the UK, the prevalence rate is pretty much the same. So that's great. It means we're doing the same as in other locations, but 6%, as a midwife, I'd like to see that higher. There are variations noted in the birth setting and the geographic location in which water birth takes place. And, some of this could be accounted for by infrastructure, availability of pools, availability of staff who are comfortable in providing water birth, the variation in health policies between different settings. We don't know for sure what the situation is in Ontario, but that's what the literature suggests in other locations that explain those variations in birth setting and geographic location. There are potential variations in uptake by race, but I think it's important to point out that when we looked at the baseline characteristics and found that water birth clients were more likely to be Black or Caucasian, there was a high degree of missing data there, like 45% missing data. So we're not clear on whether we're looking at a true relationship there, or that amount of missingness makes me reluctant to say that there is something going on, but I would certainly like to explore that further. Because if, for example, Asian clients are less likely to take up water birth, it would be interesting to know why. And tailor midwifery care accordingly. Good news that outcomes are for childbearing people and clients are similar to land birth. So that's great news to be sharing with our clients. And water birth is associated with a moderately lower risk of neonatal resuscitation and slightly higher likelihood of maternal intact perineum. In terms of the strengths of this study, it was a great bonus that we were able to use linked provincial level data. It's a population level study. So it's very robust. And we had a lot of expertise on the team between the researchers and our advisory group. So we had a lot of people who had the context to help us to design and interpret the study. In terms of the limitations, as I mentioned with race data, there was a high missingness. And so it's unclear if there's differences, true differences, or if it's just because there's missing data. The data variables that were inborn were not always indicative of the variable we were interested in. So sorry, the wording on the slide doesn't look all that clear. But the example that I'm using is we wanted to know how many clients at least experienced water immersion. So in the land birth group, it would have been really great to know how many clients had water immersion, but then got out and delivered on land. But the only variable that we could use inborn was a supportive care variable for pain management that was the use of the tub or the shower. And that's not the same as water immersion in a tub, in a pool. So, we couldn't quite fit that variable as well as we would have liked. And then some data just weren't available. So I had mentioned earlier in the background that there was some controversy over cord avulsion, and we would have really liked to have studied rates of cord avulsion in this data set because there's high numbers. Cord avulsion is likely to have shown up. Unfortunately, it's not collected by Born. So, that's something to consider as well. And then finally, the data currency. So the study was done only up until March of 2021, which is now, 3.5 years ago. So we do know that an update of the Born data set is going to become available in the next, hopefully in the next year. And that would be great to be able to follow up with that. So in terms of implications, recommendations for future practice policy and research, this is great news. I think this study, I hope, will help midwives and clients in making some personal and professional decisions around the use of water birth, the use of water for birth. But it needs to be tailored. The findings need to be tailored for specific audiences. And by specific audiences, I mean clients and midwives, but also other healthcare professionals and decision makers. who are trying to figure out where to allocate their funding. There's implications for policy in that these findings can definitely support local and provincial water birth guidance. So they're, an important step, I think, in having a good evidence base for water birth in the province. And then in terms of future research, we're going to there's a lot of knowledge translation that could be done to share the findings. And we've submitted a CIHR proposal to do a knowledge translation study with those audiences that I mentioned. And we're in the process of completing a CIHR proposal for a provincial survey that could assess water birth knowledge, attitudes, beliefs, and hopefully policies amongst clients, midwives, managers, obstetric staff, and so on. And then maybe this is a good opportunity to explore ways to incorporate new data collection items into Born that will support further collection of evidence around water birth. For example, specific items that measure whether or not clients had water immersion in labor, whether or not cord avulsion took place, and controversially, race or ethnicity data. And that would enable us to do a better update study when the next Born update becomes available, as I say, hopefully in the next year. So that's all I've got to share with you today. I definitely want to acknowledge the wonderful advice and efforts of our advisory group, who are all listed here. Our ICS data analyst, Priya Premranjith from McMaster University, and my project coordinator, who was also my grad student, Shakiba Kamalinejad. So it was a mighty team of researchers, and I'm very happy to be presenting on their behalf today. So that's it from me. I look forward to some questions.
Thanks so much, Ginny. That was so good. I have questions, but
Go for it.
I will let other people ask their questions first. But yeah, really great to hear those insights that you gained from this research. And I think, yeah, there's lots of opportunity for where to go next. So we can do question and answer in a variety of ways. So people can raise their hand and I can call you out and you can kind of just go ahead and speak freely when it's your turn. If other folks have things they want to type in the chat, I will keep an eye on that and try to flag them for Ginny as well. So why don't we start with Ethel? Do you want to ask your question? And we can't hear you.
Hey,
Uh, do you want to unmute here? There you go. Perfect.
I hope this will work because I'm in an old house where the reception isn't good. Ginny, that was absolutely marvelous. And I think it makes a really, really important contribution to understanding because you were so clear. The modeling, the standard, tip top. And I am so delighted to have listened to it. I suppose I have lots of questions, but I don't want to be hogging. I just wanted to ask, can I ask one or two quick ones?
Absolutely.
Thank you. I just want to ask about, so some of the women who had land births, um, they did use water, yes? Did I get that right? But you just don't know the proportion.
yes, because that supportive care variable.
Yeah.
You know that thing, I remember you presenting at the International Labor and Birth Conference a couple of years ago, and you were saying
Yes.
about how frustrating it was that you couldn't identify whether they were actually in a proper pool or not, or just a
That's
bathtub.
right. But and also, not all in the UK anyway. They don't. Not all the stupid EPR system. They don't all speak to each other. Point one. Point
Yeah.
two. They all put their different take on it, different places, and in some, the midwife, when she's thumping in the data, um, can't get past go. She has to labour in water only, but in other places she can override that. So we
Um,
don't know. Also, in some places, actual water birth is not, and this is a chestnut, SVD is always there. Those key codes are always mode of birth because it's money, isn't it? In the trust, the mode of delivery. But there's other, and this is something worthy of further collaboration, because issues you raise are very, very similar across, like, for example, a predominance of white women using the pool. And Oki's paper, she looked at units in the south of England. I know she didn't look everywhere, but I mean, the thing is, we know the obstetric unit underuses its pool. We know that midwives engage differently with women about pool according to her ethnicity. And I think there's this thing about, we don't necessarily talk to mothers about, you don't have to be naked in the pool. There's all this stuff contributing to. So, well, I could go on, but I mustn't. But thank you so much, Ginny.
Thanks, Ethel.
Sounds like a good opportunity for qualitative research or some of the future research you propose, Ginny, to look at why do people choose the pool for birth and, what is part of the motivation and the decision making that leads to that. So that'll be really interesting too as a next piece. Okay, next question is from Celine.
Whoops. Yes, thank you. I wonder if you examine the active management of third stage. And the other thing is about the time of cutting the cord and if there's a link with jaundice or something like that, because we have a lot of questions about not doing enough, by other practitioners. So that was my question.
Great question.
Thanks for that, Celine. Nice to see you, by the way. Yeah, I think we didn't have data to be able to collect the timing of cutting the cord. So unfortunately, we couldn't explore that. We did look at physiologic management of third stage, and it was water birth was statistically significantly associated with physiologic third stage management. So, and again, that might be because you've got a self-selected group of clients who prefer low intervention and they wouldn't have gone for that anyway. But it would be an interesting thing to tease out further, I think. Yeah.
Okay. Thank you very much. And thank you very much for this study, because it's important to have knowledge about that, considering the fears around that.
Yeah. Yeah. That's why I think knowledge translation is going to be so important. We just need to get to everybody that, it's okay to do this. The evidence supports it.
Yeah, and that segues nicely into a comment from Anne in the chat as well about feeling really grateful for your research on this topic and hoping that it will result in more policy change that will encourage water birth at, an institution level. And then also some of those changes you talked about in terms of even the born data that we're collecting, because it's very difficult, when you're missing appropriate ethnicity data, as we know born already is. And then the cord avulsion question is such an important one in the water birth issue, because it is mentioned specifically in quite a few of the, kind of statements about water birth. And I don't think it's a piece of data that we collect at all in born. So getting that added or some kind of way of capturing that, I think would be really useful as well. Okay, and now we have a question from Elizabeth.
Hi, can you hear me okay?
Yes.
Thank you so much. Ginny, that was a really interesting presentation, and you did a lovely job of explaining the analytic approach. I think my question is something that I'm wondering if you could speak to one of the challenges I think that I see with this work, as interesting as the results are, is that you have excluded two populations. Like, you've excluded anybody that didn't have a vaginal birth from the study cohort, correct?
Yeah.
And you've also excluded anybody who transitioned from water birth to land birth is going to be in the land birth group, right? And I guess I just would I feel like the results need to be spoken of with that context, because I think that ends up being a pretty fundamental challenge with all of the water birth studies if you don't have intention and sort of intention to water birth as your exposure. So this is kind of similar to when we're talking about studies of home birth. We have to study planned home birth, right? We have to be looking at, did you plan a home birth in order to study the safety of home birth? And in this case, you're trying to talk about the safety of water birth in a lot of your analysis, but you don't actually have intention, right, in the way that this study is set up. And you've excluded anybody who had a cesarean or who, didn't have a vaginal birth. And so I guess I just think that you're going to need to really contextualize your work with those limitations in mind and think about what that means for your results, because I think it's a pretty important limitation of what you have in this work, which I think is nevertheless interesting and worthwhile, but I think it is a pretty important limitation that you're probably going to want to acknowledge and discuss with some nuance.
Yeah, thank you for that. Good question. Yeah, I would definitely direct you towards Ethel Burns, because I know that she's looking at water birth in complicated pregnancies. So that work is being undertaken elsewhere. But for the purposes of this first look at what's going on in Ontario, this is what we started with. And I would have loved to have been able to say planned water birth, planned land birth. There was no data in Bourne. Like we couldn't collect it. So again, that's a great point, and I will put that in my limitations about the need for that. So thank you very much.
Yeah, it's interesting. So some of the questions that are in the Bourne data set are there because of the early midwifery data that was gathered in Ontario. And we always distinguished between planned place of birth and then actual place of birth. And so in the Bourne data set, it mirrors that. But water birth was only added, I think, at the same time when your cohort study dates back to at 2017 or something. It's a relatively new variable that got added to Bourne and doesn't have any distinction between plan versus actual. It's only like, did the person give birth in the water? And even the fact that you had to, Ginny, go back and look at use of water for pain management, like in a very other kind of convoluted piece of the data, I think really speaks to like, we just don't have that understanding of how all of those pieces would fit together. So I think this is a great start. And yeah, rightfully, that's a limitation of this study, but I think it gives us a direction for more research to figure out, are there differences, when we want to be more descriptive of the safety pieces.
Yeah, it sure does.
It's fascinating, though. I think I had a question too about when you were looking at the location, and because prevalence over time, like I think one of the things that's changed in Ontario as well is more hospital acceptance of water birth. And that's really a very recent thing that, hospitals will have their own protocol and work collaboratively with midwives to support that. And so I wondered, when you have your slide around the prevalence based on like location, it'd be interesting to also maybe look at that over time. So like the hospital water birth, has that increased in the last, few years, or has it stayed steady? So that may be another piece of analysis that could be interesting to break down.
Thanks. That is a really good idea. Place of birth by year.
Yeah.
Yeah. Okay. Yeah, that would fit in nicely with the research on integration of midwifery.
Yeah, exactly. Okay, but looking back in the chat too, there was another question earlier on from Zainab. I was wondering if you found that there were lower rates in hospitals are due to availability of resources, and are there many places that are equipped with tubs for birthing? And that it's hard to comment on that, isn't it, from Bourne data, because you don't know what resources are out there. You're just looking at a snapshot of what actually happened.
Yeah. And that's really why we're doing the CIHR proposal to do a survey, because we don't know where water birth is offered, which hospitals. I can kind of off the top of my head, I know which hospitals that I'm aware of, but provincially, we don't have that full picture. And if we don't have that picture, our clients don't have that picture. And that is affecting how they make their personal decisions, right?
Yeah.
Because they might not know that that option is available to them in their location or not available to them.
Yes.
So,
And they
yeah,
might not even know why they might want a water birth. And so this is where your knowledge translation piece comes into it as well, as if we're then informing the public better, did they start to advocate for more availability of water birth in different communities?
yeah.
So it's all hopefully part of the ongoing work that you're doing. This is great. Okay, let me see. There's also some other stuff coming up in the chat. Um, Yeah, Ethel has some interesting comments about mothers who give birth in the pool are not fixed about giving birth in it versus those who, kind of the people who really want to stay in the water versus like I'm open to it but don't not fixed on staying. So yeah, picking up again that kind of intention piece and even just using it for pain management would be really interesting. And Vanessa, thank you, has linked a US study a US study, a very small RCT that looked at water birth and land birth and had good outcomes. And that was a recent publication. So thanks for sharing that, Vanessa.
I'll have a look at that.
Yeah. Any other questions? Oh, yeah, an infographic in the future. I think there's going to be quite a few, hopefully, that come from this. That's great.
Yeah, and I would love to have that happen. Yeah.
I am one of the pieces I'm going to take away and keep pondering that I'm a little bit curious about is the piece about late postpartum hemorrhage.
Yeah.
And that, obviously that was your unadjusted results, and I don't think it was statistically significant, but it was one of those kind of postpartum complications that you saw that was higher in the water birth group. And
Yeah.
does make me think about what's the physiologic mechanism behind that. Do we think, infection is at play underlying that, but not captured or something? So there's still a lot of mystery or murkiness, as you said at the beginning, around some of the things in water birth and why we see some of the outcomes that we do. So important to keep doing this work.
Yeah, and it's hard to kind of identify how severe is late postpartum hemorrhage. Like,
Yeah.
but I would, to be conservative or cautious, I would say, okay, we'll classify that as severe. The thing I was curious about was neonatal resuscitation rates. Physiologically, what is going on that babies who are born in water require less resuscitation? There's got to be something going on, and it would be really interesting to study that further from a physiology point of view, and
I
that's not
think
my
I
expertise.
think it's about delayed cord clamping.
Yeah, yeah,
And I think it's also that there was something else. Oh, it was about the physiologic management of the third stage. And it's the same thing. It's because the logistics of doing, yeah, it's the hands-off piece, as Ethel says, and Barb has commented too. It's the delayed cord clamping that I think that's part of why you see that decreased need for resuscitation. We just leave the cord intact that much longer, and then we're also not going to be, moving forward with that more expedited version of third stage management too.
yeah, that makes perfect sense. But I think that's another good opportunity to advocate for it.
Yeah, exactly.
Yeah.
Elizabeth?
Yeah, just to speak to that issue of neonatal resuscitation, I think again you have to be careful because by only looking within a completed water birth group, you're sort of thinking that um, you're speaking about people who don't experience any complications, and so anybody who had fetal distress during labor or any of these complications is automatically removed from your kind of water birth group. And so when we visually, even as practicing midwives, we see like, wow, the water birth babies are so calm. We're also inherently biased because the population of people who get to a water birth have had to have a fairly uncomplicated labor. So it is this really tricky thing about selection bias that we kind of need to think about in this type of in concluding what we can from these results and concluding things that are correct. I think we just need to be cautious about that because people saying that these things are truly caused by water birth doesn't necessarily give people kind of accurate information about the reality of planning a water birth, right?
So, but just to kind of question that, so our land birth cohort, were also low-risk midwifery clients. So they would have entered land birth with the same low risk of complications that water birth clients did. So,
Except that you've removed anybody who had a cesarean.
yep, that's true.
Right. So anybody who was a land birth, a planned land birth at the initiation of labor, who had a cesarean in either cohort is gone. And that inherently makes both of your cohorts much more low risk than they would otherwise be, and also removes anybody that developed complications. And so I think it's just, I mean, I guess I would be curious to see the entire analysis if you left the C-section people in there, but that'll just make the water birth look even better because the same problem applies, right? Like anybody who had a completed water birth didn't obviously have a C-section, right? But that is the issue with this type of analysis, right? You inherently have made your land birth cohort kind of lower risk than it might otherwise be. So I actually think you're potentially even underestimating the sort of benefit of water birth in some ways, but you might be overestimating it in other ways. And I think that's just again, it's the challenge with doing what you can with the data you have. But it is something that I think is going to come up when you have to interpret these findings. And also it makes it slightly more nuanced if you're trying to provide informed consent, kind of relevant information based on this data, because this doesn't, as a person who might be planning a water birth, this doesn't tell me what my risk is if I didn't have a water birth. And there is other work that's done that, right? But that is the tension, I guess.
Okay, thank you so much. It's
sorry.
Oh no, I really appreciate it. I've been geeking out over this stuff for the last year, so it's wonderful to be able to share it with everybody and kind of have some groupthink about how to take it forward. So much appreciated.
And I think because it is the first study on this issue in Ontario, it is like now the starting point for all of the future research questions, which is where we inevitably have to begin, is with the data we have, and then start to kind of push those boundaries and think about what data do we want to have to really understand this picture more fully. So you have to start with the descriptive, idealized state and then dig deeper. So we start where we start and then we go from there. And I think this is
I will say it could be, Beth, it could be something to think about adding to Born if that's ever a possibility to add to get intent water birth. You know, like, did you intend to birth in water at the onset of labor? If that could be added, that would really get at this issue. And then you can do a study where you can actually look at intention to birth in water.
Yes.
And or did you use water for labor immersion? Like all of those pieces, but you really need that data. It's really the same issue as the home birth study problem, right?
Yeah. Well, the recommendation will go into the manuscript, so thank you.
This is a really exciting discussion. I am sad to cut it off, but we are at the end of our time. So we've put up our speaker series poll where you can share feedback about the rounds that you've been listening to today. And thank you so much, Ginny, for sharing your work with our audience. I think this is a great place to share this story and to keep asking questions about where we go next, which is really lovely. And I hope everybody can join us again in November when Celine and Raymond will be presenting. The title for their talk is Revisiting Professional Identity Markers Through Participatory Research. So we're really excited to hear that in a few weeks' time. If you don't already follow us on social media, this is a great opportunity to do so. That's where you'll see all of our talks advertised and highlighted, and the links to access things will be there as well. Also on our website, which is www.mmrc.mcmaster.ca, is where you can find previous presentations from our round series and publications from our group, etc. So it's a great resource to go back to. And then I think we have one final slide here just to show you the save the date for our research symposium, which is coming up on March 27th, 2026. It will be a half-day virtual setting, so 12:30 to 4:30, and we have the topics are coming together, and it's going to be a really exciting afternoon together. So mark that on your calendar, and we will circulate more information. We have a registration link available. So thank you so much, everyone, and thank you for joining us. We hope you have a good rest of your day, and we'll see you in November.